Shreyas Ramamurthy is again a consultant cornea, cataract and refractive surgery and a very dynamic, amazing surgeon. And he is going to tell us what goes into planning for INTAC segments. On to you, Shreyas.
Thank you so much for having me over, and thank you, Sheetal, for allowing me to go ahead. So today I'm going to be quickly talking about choosing the ideal intracorneal ring segment. I think a lot of us have been using the intracorneal ring segment for a number of years now. But with the advent of various protocols, topo-guided treatments, where does INTAC fit into today's treatment is also something I'd like to cover. Before that, I'll go on and talk about how INTAC works and the planning which goes into choosing the ring. So essentially what INTAC does is by creating a kind of a localized steepening at the area where the INTAC is implanted. And this mid-peripheral steepening leads to a relative central flattening. And this central flattening is what gives us the flattening of the cone and gives you the overall visual benefit. So this originally was indicated for myopia, but we've obviously stopped using it for myopia and mainly using it for keratoconus and post-LASIK ectasia. I won't really say PMCD is an indication, not the true PMCD, but the pellucid-like keratoconus or the inferior keratoconus is where it is being used, not the classical PMCD as such. Of course, it needs a central clear cornea. Any central scarring is not in those patients. They would either go in for a contact lens or a DALK procedure. Contact lens intolerance, primarily because the aim of INTAC is to post INTAC contact lens fitting will be very difficult or can be more challenging, and therefore you want to avoid contact lens and choose cases in such a way that post INTAC you give them a reasonably good best spectacle corrected visual acuity. Choosing again eyes keratometry between 46 to 60. Anything beyond 60, the amount of flattening which the intracorneal ring segment is going to provide may not be sufficient to significantly improve the quality of vision. Thickness, generally we try to have 450 micron at this is zone of implantation. So at around the 6 mm zone. The center may be much thinner than that, but that doesn't matter. It's mainly at the zone of implantation where it's important. BCVA 612 or less, primarily because in patients with very good BCVA, although with the current nomograms, we don't really see loss in lines of BCVA, but the older nomograms showed that patients with good BCVA, that is 6.6, 6.6 part, 6.9, had about a 25 to 30% chance of losing one line of vision acuity. Whereas patients with poorer visual acuity definitely benefited more with intracorneal ring segments. However, having said that, the chances of losing BCVA with current nomograms is quite unlikely. I will be primarily talking about INTAC, although Kera ring, Ferreira Mayo ring, and a host of other rings out of Brazil and Argentina are available. But I'll primarily talk about the INTAC planning. So preoperative spherical equivalent, location of the cone, and the amount of asymmetric astigmatism is what is going to decide the number of rings that we use, the thickness of the rings, and the arc length of the rings as well. So essentially, when we say preoperative spherical equivalent, this is going to decide the thickness of the ring. And we either have an INTAC which is implanted in the 7 mm zone, or more often we use the INTAC SK or INTAC severe keratoconus, which is implanted in the 6 mm zone. So closer to the central of the cornea, greater the effect. So as you can see here, slightly less, the thinner segment gives a greater refractive effect when it is implanted towards the center of the cornea. Next comes the location of the cone. We look at the posterior float and see if the cone 50% of it is within the 3 mm zone, then we call it a centered cone. If it is 50%, more than 50% is outside the central 3 mm zone, then we call it a decentered or an eccentric cone. The reason is this is what is going to decide the type of segment that we are going to use. So if it is a symmetric cone, as in this condition, then we will use symmetric segments, centered cone, symmetric segments. And if it's a decentered cone, then we use asymmetric segments, that is a thinner segment superiorly and a thicker segment inferior. We also look at planning the incision. Now, when we are looking at the incision, what we are going to do is look at 4 parameters. One, we look at after transposition, on the topography, the steep axis, on subjective axis, the steep axis. Then 2 other parameters. On the posterior float, from the central point to the maximal point, we draw a line and extend it on both directions. This gives you the flat axis. The line perpendicular to that gives you the steep axis. Similarly, on pachymetry, from the thinnest point to the central point, take those 2 points and draw a line on either side, and perpendicular to that is likely to give you the steep axis. Now, this is a case where it's specifically chosen where everything correlates beautifully, but it may not be so in every particular case. But you want to try and either repeat your refraction or repeat your scans to ensure you're more or less having the correct location of the incision. Again, this is only primarily to decide the location of your ring also, because we are going to implant it about 30 degrees beyond the steepest incision is where the ring is going to start, and that is where it becomes more important. The incision itself does not have a great impact on the overall visual outcome. The other thing is once you've located this, so this is a central cone, like I mentioned, we are going to have and look at the spherical equivalent, and looking at the spherical equivalent of this particular patient, we are going to choose the kind of thickness of the ring segment that we are going to choose. So for an 8 diopter, as you saw in that example, we are going to use 0.45 symmetric segments. But looking at the other example, let's say a decentered cone, like in this particular patient, in decentered cones or where we use asymmetric segments, it's the cylindrical power that we are going to look into while choosing the ring from the nomogram. So in this particular, even after transposing, the cylinder magnitude is not going to change. So 3.5 diopter, as you can see in this particular individual case. And once we again look at the nomogram, and as you can see here, for that we'll be using a 0.21 superiorly and a 0.35 inferiorly. So it's the cylinder power which is going to decide the extent of thickness of the ring that we are going to choose. And usually, because it's decentered inferiorly, we have the thicker segment inferiorly and thinner superiorly. So this is basically about symmetric and asymmetric segments. Now, we also have an option of using a single ring. So basically what happens is, when we are using 2 rings, we are trying to flatten the cone to the extent possible and giving an overall reduction in the spherical equivalent, flattening the cone and improving the visual acuity. Whereas with a single ring, there is a greater reduction in the astigmatism or the ISC symmetry. So whenever you have a higher ISC symmetry of greater than 10 diopters or so, then in those cases you do well to do just a single inferior ring, which helps in trying to shift the cone a little superiorly by causing a relative flattening inferiorly. So thereby the overall best spectacle corrected visual acuity also improves. So this is just one such example where you can see there's almost 10 diopters of ISC symmetry, and those patients do well. Then you have the smaller arc segments. So normally the regular segments which I was talking about are the 150-degree segments. Now you have 90 and 130 also available. So it was found that to have a localized effect, from progressively increasing from 30, 60 up to 90, you have maximal effect along that axis. Beyond 90, it has an effect on the opposite axis also, and therefore causes a greater reduction in the spherical equivalent. Whereas up to 90, there is a greater reduction in the amount of cylinder or the power along that particular axis. So in patients where the myopia is already less, or in rare cases who have a slight amount of hyperopia along with astigmatism, so in those cases, you don't want a global flattening and cause a greater amount of hyperopic shift. And in those cases, you can use a smaller arc segment, like in this particular example, with the patient as accepting a low-grade hyperopia, but predominantly a cylindrical power, and where these arc segments work well. So where does INTACs come in today's options? Generally, in a centered cone, if there is sufficient thickness, we go ahead with a topo-guided PRK and improve the quality of vision. And if there is a significant residual error, we could either give glasses, contact lenses, or a phakic IOL. But if it's an eccentric cone, the topo-guided PRK procedures work a little less, are not as effective. So in those cases is where INTACs becomes very useful, as well as in post-LASIK ectasia, where very often it is an eccentric cone. And in those cases, you could implant a intracorneal ring segments. Like I already mentioned, contact lens fitting following intracorneal ring segment can be more challenging because you have a flatter center and a steeper mid-periphery. But of course, there are lenses, Rosque IC and miniscale lenses which are available, which can be done post-INTACs. But in today's practice, I consider it a failure of case selection and using the INTACs if you're anyway going to put the patient on contact lenses, because most of these patients could have been fitted with the contact lenses even before the intracorneal ring segments. Topo-guided PRK or PRK can be done following INTACs also if sufficient thickness is there. However, there is an increased propensity for haze and epithelial hyperplasia along the channels, and this is something that you need to be watchful for. After intracorneal ring segments, if the best spectacle corrected visual acuity has improved significantly and the patient is comfortable with the spectacle corrected visual acuity, I'm sorry, the video doesn't seem to be running. But after that also, a toric phakic IOL can be used to debulk the amount of anisometropia that the patient might be having, and thereby improve both their uncorrected as well as best corrected visual acuity. So intracorneal ring segments is the only device which can mechanically shift the cone at this point of time, and careful case selection and good preoperative planning can give optimal results. Thank you so much.
Thank you very much, Shreyas. Sheetal, share your screen. Shreyas, I'm going to take a question with you. How have we modified our INTAC's case selection with time, with experience? What do we do now?
So I think, in many practices, I think the number of intracorneal ring segments which was being done, let's say 6 or 7 years ago to now, has probably come down a little bit because our case selection has improved, and we know where topography guided PRK works. We were probably not doing as many topography guided PRKs a decade ago as we are now. And the case selection, understanding, follow-up outcomes of that has improved. So early moderate keratoconus, that is becoming the treatment of choice because the outcomes are far more predictable with a topography guided treatment than you have with an intracorneal ring segment. Having said that, it is still a useful device in that segment of patients where, like I mentioned, with the preoperative characteristics, there you can definitely use an intracorneal ring segment, improve the quality of vision, and then go ahead and do other refractive procedures to further improve that vision.
Thank you, Shreyas, for a wonderful talk and discussion.